I would like to introduce our first speaker today. She is our keynote speaker. Her name is Dr. Elena Elimova. She is a medical oncologist at Princess Margaret Hospital. She previously completed her fellowship at MD Anderson. She is my boss, my personal mentor, and actually it's her son's birthday today. So it's a real honor and treat to have her today speak for us. Dr. Elena Elimova.
I just want to start off by saying thank you so much for having me here, and it's a real pleasure to be here with you today. So I'll move right into my talk. I'm going to be talking to you about gastric cancer care and research and where we are now, and a little bit about where we'd like to be. So as Katie mentioned, I'm a staff medical oncologist in gastrointestinal oncology department at the Princess Margaret Cancer Center. I actually trained in biochemistry at Queen's University a very long time ago. And then I went to medical school in Newfoundland. So I'm still an East Coaster at heart. I was a resident and then a fellow at University of Ottawa and University of Toronto. But then eventually I went to the MD Anderson Cancer Center in Texas, where I did my GI medical oncology fellowship. And then I actually worked there as a staff before returning to Princess Margaret. My main research interests are understanding clinical and molecular characteristics of gastric and esophageal cancers, clinical trials, quality of patient care, and outcomes. So I want to start by talking a little bit about the epidemiology of stomach cancer. So stomach cancer is actually not an uncommon cancer. It's the fifth most commonly diagnosed cancer in the world. There's more than 1 million cases that are identified each year. It is more common in people who are older, in men, in people of in Eastern Europe, Central Asia, and Latin America. 95% of all stomach cancers are adenocarcinomas. And when we talk about adenocarcinomas, that refers to how a cancer looks under a microscope to a pathologist. There are other more rare forms of stomach cancers, for example, lymphomas. But people like me or medical oncologists don't treat these cancers. These cancers would be treated by blood cancer specialists. I want to touch on some risk factors for stomach cancer, but I also want to tell you that having a risk factor doesn't mean that you're going to develop stomach cancer. So having a risk factor doesn't mean that that risk factor will cause your cancer. First, let's talk about H. pylori. H. pylori is very common. There's an estimate that potentially about 50% of all people in the world are actually infected with H. pylori. And H. pylori is known to cause ulcers. It's also known to increase the risk of stomach cancer, but of course we know that not half the people in the world go on to develop stomach cancer. Also, gastroesophageal reflux disease is known to be a factor, being obese, and then certain dietary choices. So stomach cancers were very common and still continue to be common in countries like Japan, and that has to do with consumption of certain types of nitrated foods. When patients come to see me, they say, Dr. Elimova, is my cancer caused by my genes? And I tell them that hereditary stomach cancers are very rare. As you see, only about 1 to 3% of all stomach cancers are linked to a genetic disorder. So what I tell my patients is that probably what causes stomach cancer is some combination of the genes that we're born with and the environment that we live in. But we still don't know everything about what is the cause. Today, I'm going to be talking to you about stomach cancer in particular. So this is a picture of the esophagus, and then as you move down, you can see the connection between the esophagus and the stomach, and then the stomach. So the stomach cancer can be separated into cardia or non-cardia subtypes of stomach cancer, but what I'm going to be talking to you about is right here, okay? So what are the signs and symptoms of stomach cancer? Well, I think stomach cancer is a very silent disease, and that's why patients with stomach cancer are often diagnosed at later stages. And what I mean by that, I mean that the cancer has already spread to other parts of the body. Signs and symptoms can be missed or can be thought to be caused by something else. So, for example, what people would describe as feeling full early, having difficulty swallowing, losing weight when they're not meaning to lose weight. A couple of things that I worry about, and I always, when I give talks, I mention, if you have reflux symptoms and your doctor prescribes anti-reflux medication like a proton pump inhibitor, and those symptoms don't go away, I think it's really important to tell that to your family doctor because maybe some additional testing is needed. The other thing that I worry about is anemia in people. So having a low hemoglobin without having another explained cause. So for example, women who are having are of childbearing potential, are menstruating, that's a very common cause of anemia. But not having an explained cause should probably prompt some additional investigations. So how do we diagnose stomach cancer? And I think this is another question that people ask me all the time. Well, the most important test is a gastroscopy and biopsy. So you will go to a gastroenterologist who is a doctor who would put a small camera through your mouth and look at your stomach. They would actually be able to visualize a tumor, and they would take small samples of that cancer to be sent to a pathologist. The pathologist looks at these samples, and that's who gives us the diagnosis of stomach cancer. And the pathologist also may test for do some special stains for biomarkers that might be important in telling us how we should best treat your cancer. Once that test is performed, and if you've been diagnosed with stomach cancer, your doctor will order CT scans. And CT scans are important because they allow us to look at other parts of your body where the stomach cancer can go to. So for example, stomach cancer can go to the lungs or the liver, bone, and CT scans would help us look at those other spots. PET scans are not typically used to stage stomach cancer, and the reason is that PET scans don't add a lot to a CT scan. In addition, they're not very good looking at looking at the abdominal cavity, which is commonly one of the common places where stomach cancer will spread to. So for patients who have CT scans that show no evidence of disease spread, it's important that they have an additional test to look at their abdominal cavity. And that test is called a laparoscopy. That test is performed by surgeons. A few small incisions are made in the abdomen, and the surgeon puts a little camera in and then looks through the abdominal cavity. So you may ask, why is it important to do a laparoscopy? And the reason it's important to do a laparoscopy is because even when we see nothing on a CT scan, meaning that there's no evidence that the stomach cancer is spread, in about 20% of patients, we find spread in the abdominal cavity, which is also known as the peritoneal cavity, and that changes how we treat patients. Next, I wanted to touch a little bit on what localized cancer is and what metastatic cancer is. So when we talk about localized or locally advanced stomach cancer, we're talking about half the patients that we see are diagnosed with locally advanced disease. That's stage 1 to 3. That means that the cancer is confined to the stomach and the surrounding lymph nodes, meaning only the regional lymph nodes. About half the patients we see, unfortunately, have metastatic disease, that's stage 4 disease. And that means that the cancer has spread to other parts of the body. So that could be distant lymph nodes, so lymph nodes in the chest or really low down in the abdomen. It could mean to the liver, bone, to the abdominal cavity, what I was talking about, the peritoneum. Why is it important that we know the stage of your cancer? Well, it's important to know that because it affects how we treat the cancer. When we talk about curative versus palliative intent, what does that mean? Curative intent means that we're giving you treatment to try to eliminate the cancer completely. And we do that when the disease is localized. Palliative intent talks about shrinking or controlling the cancer. And that happens in cases where a surgeon can't cut out the cancer, or in patients in whom the cancer has unfortunately already spread to other areas of the body. Next, I want to talk to you about the treatment of stomach cancer. And when I sit down and I talk to my patients, I tell all my patients, and they know this, that stomach cancer treatment is really complicated. When we decide on the best treatment options for patients, particularly those patients with localized disease, it's not just me who makes a decision. It's my surgical oncology colleagues. We sit with pathologists and radiologists, and we come up with the best treatment plan for that individual patient. What I'm going to talk to you about the general recommendations that are put out by groups like Cancer Care Ontario. But what I want you to realize is that each patient's treatment plan could be different because of their age, because of the other health problems they may have, because of how well they're feeling, what we call their performance status, or because of their goals or wishes. So I think what's really important is that you yourself discuss your treatment plan with your medical oncologist and other parts of your healthcare team. So when we talk about treatment of locally advanced stomach cancer, the standard of care in Ontario in patients who are fit are 4 cycles of preoperative chemotherapy. And that chemotherapy consists of 4 drugs usually. It's called FLOT. I'm not going to go into the details of what those drugs are. Following those 4 cycles, the patients have new scans. They need to go to a surgeon. And if everything looks good and there's no evidence that the cancer has spread and it's still resectable, they will have a resection, meaning a gastrectomy. Their stomach is removed. Following this, the patients come back to see me, and we give 4 more cycles of postoperative FLOT chemotherapy. I always tell my patients that the 4 cycles of postoperative FLOT chemotherapy are difficult to give because after surgery, a lot of patients lose weight, they don't feel as well. And I always remind them, even if we can't finish all those 4 cycles, I don't worry about that too much because most patients on that trial didn't finish all cycles of chemotherapy, right? So, and then when we finished all treatment that the patient can tolerate, what we do is we put patients on active surveillance. And what that means is we follow them with CT scans and sometimes also endoscopies or gastroscopies. When we diagnose a patient with metastatic cancer, meaning that the cancer has already spread, the treatment is different and it's pretty complicated. I'm going to do my best to kind of give you an overview of how we treat patients with metastatic disease. But what I will say is that when I see a patient who's having a lot of pain or whose tumor is bleeding, that's a time to consider sending that patient to a radiation oncologist who might be able to offer some radiation. But the main treatment for disease that spread has to be a treatment that goes everywhere. And so that refers to systemic treatment or chemotherapy and sometimes targeted agents. What we give patients as a first treatment option depends on some of the stains that our pathologists do. And I'm going to talk a little bit more about that in a second. But in essence, if patients have HER2 positive stomach cancers, we'll give them chemotherapy with another drug called trastuzumab. If patients don't express that protein, meaning that their cancer doesn't have that protein on the surface, they have HER2 negative stomach cancer, and then we test for some additional markers, some of which are actually quite new. Mismatch repair enzymes are tested, and I'm going to tell you more about what that means. And then a new biomarker, which Katie has alluded to, can be tested through a compassionate access program. It's called Combined Positive Score, and I'm going to explain to you what that means. But what I will tell you is that if my patients have a combined positive score greater than or equal to 5, then I consider adding immunotherapy to chemotherapy. And again, I'll talk to you a little bit more about that down the line. Once the first treatment we give stops working, there are other drugs that we can give. There are drugs like paclitaxel and ramucirumab, there is fulfuri, and there's a drug called TAS-102. How I decide what treatment to give next depends on the type of side effects my patients have. But what I want to highlight is that we do have treatment options in metastatic disease, and we have many more options than we had even 10 years ago. I think tumor biomarkers are very important in the treatment of stomach cancer. I just want to highlight for you what's standard of care. So standard of care is a protein called HER2, mismatch repair, and I've just alluded to this combined positive score or CPS. I'm going to talk about it more in a second, but it is covered through a compassionate access program. The thing that patients most often ask me about when they come to see me is about additional testing that's not covered by the Ontario government. So next generation sequencing or NGS, so an example of that would be something like Foundation Medicine. is not covered by the Ontario government, but it can be obtained through either clinical trials or people can pay for it out of pocket. You need a medical oncologist or a healthcare provider to order it for you, and you have to fill out some forms and work with your medical oncologist to do this. What's the utility of next generation sequencing? Well, it's helpful in not when we're starting treatment, but let's say that we have run out of treatment options and we want to look for other things that might be reasonable. If you find a mutation in your cancer, maybe your medical oncologist could send you for a trial that targets that particular mutation. And that's where it's helpful. I often tell my patients this costs money, and the chances of finding these mutations are actually fairly low. Gastric cancer is not actually a disease of mutations. I think of gastric cancer more as a disease of amplifications. But I think it is, for people who can afford it, it's reasonable to do. Because it might open up more treatment options if patients are strong enough down the road. So let's talk about tumor markers and HER2. So HER2 is a human epidermal growth factor receptor 2. It's overproduced in a lot of cancers, which includes stomach cancer. As a standard of care, it's tested by pathologists in Ontario, and the testing is done by staining the tumor tissue. But only 18% of all stomach and gastroesophageal cancer patients will have that protein. Only if you have that protein would it be recommended that trastuzumab is added to your treatment. What about immunotherapy? There are 2 tumor biomarkers that have been helpful in telling us if patients are going to respond to immunotherapy. One is called MMR, and the other one is called combined positive score. Immunotherapy activates your immune system to kill cancer cells. An example of immunotherapy includes nivolumab and pembrolizumab, but what we have to realize is that immunotherapy has additional side effects that are unique to immunotherapy and are different from chemotherapy and might not be right for all patients. So let's talk about mismatch repair. MMR proteins are used by normal cells to correct DNA replication errors. When you have a mutation in these proteins, they increase the risk of developing a cancer. But only less than 5% of patients with stomach or gastroesophageal cancer patients are MMR deficient, meaning that they have MSI high, microsatellite unstable high cancer, meaning that they have lots of mutations in their cancer. Patients who are MMR deficient or have MSI high cancers respond better to chemotherapy and immunotherapy, such as nivolumab. And nivolumab was recently approved by Health Canada, but it's not yet covered by the Ontario government. Out of pocket, the cost of nivolumab is high, but I think it is important and worthwhile to talk to your medical oncologist if your tumor is known to be MMR deficient or MSI high. And also, you can look into coverage through your insurance provider or your drug coverage plan. The CPS is a newer biomarker, and I think is equally important. It's called a combined positive score. So cancer cells express proteins that help them evade the body's immune system. PD-L1 is expressed in your normal cells, and it helps your immune system so it doesn't attack your normal cells. But cancer cells are smart, and they can express high levels of PD-L1, and in this way, they hide from your immune cells. So CPS is a score that quantifies the amount of PD-L1 in your tumor and the surrounding cells. So why is CPS important? Well, this is a study that that my center participated in, and I had put a lot of patients on. It's called the Checkmate 649. It was a phase 3 clinical trial that's published in Lancet. It looked at patients with advanced stomach cancer, and it randomized these patients to receive standard of care chemotherapy, which is FOLFOX or Xelox, and then chemotherapy plus immunotherapy, which was nivolumab. The most important result of this study is that in patients who had this combined positive score greater than or equal to 5, the addition of immunotherapy helps these patients live longer by 3.3 months. So CPS testing is not standard of care in Ontario. However, it can be obtained through a compassionate access program, And your medical oncologist may also be able to obtain nivolumab if you meet all of the criteria of this program and you're starting a new treatment in the first line, so meaning the first treatment. The last thing I wanted to touch on, and this is a very common question that I get asked about because I work at Princess Margaret Hospital: clinical trials versus standard of care. So what are clinical trials? Well, clinical trials are research to assess the efficacy, effectiveness, and safety of a novel intervention compared to standard of care. And standard of care is usually chemotherapy. I think that a lot of patients come to see me and they believe that clinical trials are a better treatment option than standard of care, but that is a myth. The truth is that nobody knows whether a novel intervention is going to be better than the standard of care. That's why we're testing the experimental drug in countries across the world to see if it can help. I tell my patients that it's important to decide if a clinical trial is right for you. And how do you do that? Well, you do that by talking to your medical oncologist. The things that you should take into consideration are how far you have to travel to the treatment center, how the screening window is going to affect you. So because you have to do particular tests to go on a clinical trial, for example, you might need to have a biopsy, you might need to have new CT scans, it might delay your treatment by 2 to 4 weeks. Now, not every patient with stomach cancer can wait 2 to 4 weeks to start treatment. The patients in whom I do not recommend delaying treatment are patients who have a high symptom burden, they're not feeling well, or who have a high volume of cancer, meaning maybe their liver is almost completely replaced by the cancer. The reason I do not recommend going on a clinical trial in these patients is that while waiting to go on a clinical trial, they may well miss the opportunity to receive what we call standard of care treatment for their stomach cancer. And of course, we know that standard of care works. I think the other things to consider are the additional tests, things like biopsies or scans. You have to take into consideration your quality of life. And I tell my patients, you have to be comfortable with uncertainty because we could go through all of the testing processes, but we have to click all of the check marks for them to be able to go on a clinical trial. So at the end of the day, we could be planning to start the treatment. The patient comes in, we do blood work on that day. And if the blood work is not within the ranges that are determined to be safe by the clinical trial, the patient still can't go on the trial. So what are the clinical trials that are available through Princess Margaret Cancer Center for stomach cancers? We have a lot of different clinical trials available either through my group or through the phase 1 group. A lot of the trials that we're doing now look at patients with HER2 positive gastroesophageal cancer. So that was the biomarker that I talked to you about a little bit earlier. I think if you're interested in clinical trials, what I advise you to do is to talk to your medical oncologist. At Princess Margaret, we get a lot of referrals from different doctors, but the referrals that we need are referrals from medical oncologists. And the reason that those referrals are so important is that another medical oncologist will know what we need to know to tell them if you might qualify for one of our trials. So I really stress this to my patients, and I always encourage them, if they have any questions, please talk to me, because medical oncologists don't mind sending you for trials if they think that's the right option for you. I also try to empower my patients. I always know about the trials that are available at Princess Margaret Hospital, but there are many trials that are going on all over the world. And the way that you can find out about those trials is by going on this international clinical trials database, which is called clinicaltrials.gov. There you can search any trial in gastroesophageal cancer that's happening really anywhere in the world. It won't tell you whether you'll qualify for the trial, but what it will tell you are some basic, what we call inclusion or exclusion criteria from the trials. And what you can do is you can print out that page and take it to your medical oncologist and have a further discussion about whether that might be the right match for you. What about clinical translational research studies? This is different than clinical trials. So, clinical and translational research studies are different. They're done by clinician scientists to understand more about the disease and hopefully contribute to the development of better diagnostic or treatment options, probably many years down the road. The myth is that clinical research studies are the same as clinical trials, but they're not. So the truth is, clinical research studies are not the same as clinical trials because there's no intervention or experimental drug that's often offered. So then patients who come to see me, and when I offer them these clinical research studies, they say, well, why should I participate in this trial? And what I tell them is that most of my patients who go on these studies have a desire to contribute to the scientific discovery and to help future patients with the same cancer. I think the things that are important to consider now, remembering that you're not really getting a novel drug or treatment, are the distance from home that you have to travel to the cancer center. Again, there is a screening window even for these studies where additional tests or perhaps a biopsy have to be done. And again, these trials can delay you getting on treatment by 2 to 4 weeks. You have to think about your quality of life. And again, you have to be comfortable with uncertainty. Even these trials have what we call inclusion and exclusion criteria, and all of the inclusion criteria have to be met for a patient to be eligible for a trial. We do have active translational research studies, which are going on at Princess Margaret Hospital in gastroesophageal cancers. We're trying to study at things like genetic mutations and tumor biomarkers. So the last thing I want to address with you guys is, what do I think the future holds? Well, I've been practicing for about 10 years. And within the last decade, there have been new treatment options for gastroesophageal cancers. And that's really exciting for me. When I first started training as a medical student and later on as a resident and a fellow, really there was only one treatment option proven in gastroesophageal cancers. I've shown you that slide that shows that now there are many drugs that we can use. I think what's really exciting to me, particularly in the last few months, is that we've been able to show that the addition of immunotherapy to standard of care chemotherapy for metastatic stomach cancer does help some patients. I don't recommend immunotherapy for all of my patients. When Health Canada made the approval for immunotherapy, they made a particular note that patients with a higher CPS seem to benefit more. And in fact, what I will tell you is that patients with a lower CPS, CPS of 0, may not benefit at all from immunotherapy. Patients now ask me, if I have a localized cancer, would it help to add immunotherapy to FLOT? The answer is, I don't know, and no one knows. So right now, FLOT remains the standard of care for localized disease. There are clinical trials that will help us answer that question, but they're ongoing. There are new biomarkers for stomach cancers that are being studied. Mismatch repair enzymes have been studied for many years, but we're studying circulating cell-free tumor DNA, and I think FGFR2 is a biomarker that's particularly interesting because there's also a drug to target it. I think our goal as medical oncologists, as surgeons, as healthcare providers, is to balance quality and quantity of life and to really think what will benefit our patients the most. And that involves actually sitting down with that patient and having a discussion about what their goals of care are. That being said, I'm extremely happy to be treating gastroesophageal cancers now, and I think lots of new trials are coming. And I just want to thank you for the opportunity to be here today. Thank you very much.
Hi, Dr. Elimova. Thank you so much for your presentation. We're having a lot of questions coming in, and I'm just trying to kind of, streamline them. A big question that's coming up right now is surveillance. So there's a couple of questions about how often should people have CT scans. Another question, so this one's from Judy. She's a caregiver from California. She's asking, why isn't gastroscopy the standard test in monitoring for stomach cancer recurrence, since CT scans are not effective? And then another question about PET scans. So could you please comment on surveillance, so CTs, PET scans, and gastroscopies?
So I'll take it one step at a time. Okay, so I'm going to start with CT scan surveillance. The answer is no one knows how often patients with stomach cancer should be surveilled. The way that question would be answered is to do a clinical trial where we would compare patients who are surveilled by CT scans and have other patients who are not being surveilled by CT scans and are just followed for symptoms. And that trial, unfortunately, I don't think will be done. So how we surveil patients is based on expert opinion. And what most guidelines will recommend is doing CT scans anywhere at 3 to 6 month intervals. That's, again, remember, we don't have good evidence to show us that actually helps, because when stomach cancer returns, it will often return not in a localized way, but it will return distantly. And what we don't know currently is whether treating patients with metastatic disease early will help them live longer. I know that when I give chemotherapy, if a patient has a sensitive cancer, that cancer will probably respond, whether I give the chemotherapy today or 2 or 3 weeks down the road. So that's the answer for the CT scans. For PET scans, the reason we don't recommend them is probably one of the most aggressive forms of stomach cancer is something called signet ring cell adenocarcinoma of the stomach. That cancer goes particularly to the abdominal cavity. It also is not FDG avid, meaning it would not be hot on a PET scan. So actually doing a high quality CT scan is probably better at monitoring patients. Okay. I don't say that PET scans are never done in stomach cancer, because that's never true in anything in medicine, but they're only done in selected situations. And the last thing is about gastroscopies and endoscopies. And I will say that's not the fairest question to ask a medical oncologist, because I always look to my gastroenterology or surgical colleagues to answer that question. But from what I understand, the reason that stomach cancer isn't followed by gastroscopy and regularly, so it doesn't mean that patients following stomach cancer diagnosis don't ever have an endoscopy. But the reason that people are doing that endoscopy is to check for a development of a new cancer if there is remaining stomach. If the whole stomach has been removed, then you don't expect that cancer would return. You're not surveilling. There's nothing to surveil if the whole stomach has been removed. So that's my understanding of why that's not done.
Thank you so much. We're also getting a lot of questions about treatment and options in other locations. So, for example, Amy, who's from Canada, is asking, why is Canada so behind on treatment options compared to other places in the world, such as the US and Asia?
So I don't really think that's a fair assessment, because I worked in the United States probably for about 3 years. So I don't think we're behind them, because the data is the data. What I will say, in Asia, for whatever reason, when you look at their clinical trials, their patients seem to do better. And the argument is that there could be differences in biology between patients in Asia and patients in North America. I think that just shows you how little we know about the biology of this cancer and why the study of the biology of this cancer continues to be so important. In terms of treatment options that are available on clinical trials, it's not true that clinical trials are not available in Canada. They are available in Canada, and they can be accessed through either phase 1 programs or through gastrointestinal programs, depending on what stage of clinical trials you're looking at. But I think, knowing whether a trial is right for you or not, that's what's important to discuss with your medical oncologist. But having worked in MD Anderson and having worked at Princess Margaret Hospital, I think the standard of care of what we give here and what I gave at MD Anderson is really the same.
Thank you. This is another question from a caregiver. Her name is Yvonne, and she's from Oakville. Why is gastric cancer now a more common occurrence in people aged 25 to 35 years old, and especially females? Have there been causes found yet?
Yeah. So I think this is a question that we ask ourselves a lot. I don't think we have a good answer to that. This isn't true just for gastric cancer. This is also well studied for colorectal cancer, so another GI malignancy. Because think about it, it's all a continuum. Our GI tract is all a continuum. So I think that's an important area of study, but I don't think that we know the answer to that question yet. We might have identified some risk factors, but if you remember, risk factors doesn't mean causation.